So I think I can start with introductory remarks. So good afternoon, everyone, and welcome to this session entitled The Role of Research and Innovation in Enhancement of Older Cancer Patients' Care and Treatment Options, Accessibility and Quality of Life During Survivorship. I am Haris Girvalaki, the EU Affairs Manager of the European Cancer Patient Coalition, and I will guide you through the first part of today's webinar. So this is a LifeChamps EU-funded project parliamentary event co-organized by the European Cancer Patient Coalition, the Challenge Cancer Parliamentary Intergroup, and of course, all project partners. For those of you who are not familiar with the project, LifeChamps is a 3-year research and innovation action funded under the Horizon 2020 program of the European Commission. And its main focus is on delivering a smart, personalized and secure platform that will monitor health outcomes and address cancer comorbidities for older cancer patients and survivors by preventing long-term side effects and improving quality of life. So at this point, I would like on behalf of all project partners and the coordinator, Professor Panagiotis Bamidis, to warmly thank MEP Tomislav Sokol, who agreed to host this event, but also all the eminent speakers that are here with us today. Professor Nikolos Papaioannou, Rector of the Aristotle University of Thessaloniki, Professor Nicolo Battisti, President-elect of the International Society of Geriatric Oncology, Professor Mark Lawler from the Faculty of Medicine, Health and Life Sciences, Queen's University of Belfast, and also ECPC Scientific Committee member, Mrs. Alina Komanescu, the founder of Community Health Association, patient representative, and also ECPC member, and Dr. Evdokimos Konstantinidis, the president of the European Network of Living Labs. So as you all know, cancer has become a top health priority for the EU, and it is expected to have an active role in the policy agenda through the Europe's Beating Cancer Plan. In the meantime, the steady increase of life expectancy, mean age, and cancer survivorship across the developed countries, together with evidence from cancer and geriatric care research, brings forward the urgent need to deal with the age issue, let's say, as a key component of the global cancer care strategies. On the other side, increasing age and comorbidities are often associated with a discriminant lower use of several cancer therapies, as well as a higher neglection of their preferences in health-related quality of life and care support. So, at the same time, the novel technologies and artificial intelligence in digital medicine promise the transformation of health care services and offering new technological skills to clinicians that, along with their traditional and clinical methods, can lead to person-centered and effective care and treatment based on the personalized needs and requirements of the patient. I'm sure that we will have the opportunity to discuss further on this during today's webinar, but before we go into the discussion, I would like to give the floor to today's host, MEP Sokol, for a short welcoming message. So MEP Sokol, over to you.
Thank you very much. I'm very glad that I can host this event because it is part of this whole series of events that are being organized in the Parliament and around Parliament, even though in the hybrid format, related to cancer. And I'm especially glad that this happens on the day that we are voting, actually, the BECA committee on the report on the Europe's Beating Cancer Plan. So I think this is a very, very important date for the cancer patients in Europe, especially from the point of view of what the European Union can do for them. Of course, as you know, healthcare has not traditionally been a European priority. It's been really, to be honest, a marginal issue in the European institutions, but this has changed in the last couple of years. As one of the reasons, obviously, is COVID-19. Unfortunately, the pandemic. This is the reason why healthcare in general has become the priority of the European Union, but not because we wanted it, but because of the vis major, force majeure, let's say. But what is also important, the other important initiative is the adoption of Europe's Beating Cancer Plan. This was a political priority of my political group of DPP since 2019 European elections, and I'm glad that now we have the result. But also the commission which published the plan in February this year, but also that this resulted in the creation of the BECA committee, special committee on beating cancer in the European Parliament, which has successfully, I believe, finished the report on how to improve the Europe's Beating Cancer Plan to make it better, especially from the points of view of cancer patients and healthcare providers. What is important now is that cancer has become a priority that can be seen in concrete policies and concrete actions of the EU, both regulatory and fiscal, financial. So I would just like to mention that the EU for Health program has been adopted, which amounts to 5.3 billion euros, which is 12 times bigger than the amount that the previous healthcare program in the previous 7-year European budgets, which was around 450 million euros. So this has shown us that healthcare and especially beating cancer has become one of the European priorities. When we speak of research and innovation, of course, European Union has a very important financial tool at its disposal in that particular area as well, and that is the Horizon project that, of course, is also behind this event in your organization as well. And I'm especially glad that beating cancer has become one of the priority missions of the next Horizon, which again shows us how important beating cancer is within the European policies. Of course, a lot more can be done. Europe's Beating Cancer Plan provides for several concrete policy proposals and initiatives, some of them of legislative nature. We in the Parliament would like to go even further, for instance, to include the right to be forgotten, so the prohibition of discrimination of cancer survivor in the EU legislation, which the plan does not provide for. It just provides for a code of conduct. So we want a concrete piece of legislation, and also we in the report are also emphasizing the need to strengthen European Union's investment into research and innovation related to cancer. Also, I would like to mention when we speak of research in general, research on cancer and in the area of healthcare, one of the big issues is the use of data. And especially we want to conduct multinational, cross-border collaborative projects and the research initiatives in the European Union. The big problem is the use of data. So the lack of interoperability of data between different member states, the problem of different protocols, different legal and ethical rules on how to use the data, different interpretations of the GDPR, which should have result in the harmonization of the rules on how to use data, but unfortunately different member states have different ways of interpreting this, which shows us that also additional EU rules are needed in this respect. And we in the report are emphasizing the need for the European Health Data Space Regulation to be presented as soon as possible. We expect this to be made in the beginning of 2022, so that this crucial piece of legislation, which will enable cross-border use and exchange of data, cross-border collaborative projects, clinical studies, etc., will also be one important additional European tool which will facilitate innovation and research in the area of healthcare and especially cancer. So as you can see, we are doing a lot. We are trying to do as much as possible. The Parliament has always been on the forefront of this campaign against cancer. So we are the ones who always want to go even one step further than the Commission and especially the Council, which is kind of usually putting brakes and putting obstacles to some common European initiatives, especially some member states. That's the story. That's the situation as it is. But we in the Parliament are fully committed to continue our work on beating cancer even after the BECA mandate expires. So we'll continue to control how all of these priorities in the area of beating cancer are conducted, especially, as I mentioned, Europe's Health Data Space Regulation, but the other initiatives as well. And I believe that with the use of all of these regulatory and financial instruments that we can really achieve the results that we want in terms of beating cancer. And events like this are also very important to highlight some specific areas related to this. And I think that research innovation is crucial for the future of our efforts on beating cancer, especially all elderly people. So elderly people are age group which is not usually the forefront of the discussion. So usually the focus is on disadvantaged people, children, and groups like that, which is also obviously extremely important. But we should not forget about elderly people as well, and we should do what our utmost to help them as much as possible. And the European Union can really do a lot in that respect. So I'm glad that I can be host and be part of this conference, and I wish you fruitful debates. Thank you very much.
Thank you. Thank you very much for your important insights and also for your good collaboration. Fingers crossed also for the voting today that will improve the implementation of the Europe's Beating Cancer Plan and eventually treatment for cancer patients and their quality of life. So before we move forward, first to note that some housekeeping rules. Please keep your microphones muted unless you're speaking, and then you also have the possibility to post your questions or statements through the chat. Also note that this session is video recorded, and we plan to use this video on dissemination purposes on ECP's and LifeChamps websites. We will now proceed with the first part of today's event to briefly present LifeChamps project, and then the panel discussion will follow. So once again, thank you all for being here. And now I will pass the floor to Professor Panagiotis Pamidis, the project coordinator from School of Medicine, Aristotle University of Thessaloniki, to briefly present the aims and scopes of the LifeChamps project. So Professor Pamidis, over to you.
I think I would like to thank you all again, and thank you, Dr. Tomislav Sokol, for hosting this meeting. It's important that we do have political support because science is science, and care is boosted by technology these days, but unfortunately nothing can be actually facilitated and have a proper impact unless there is a sufficient policy support. But before we go to the LifeChamps itself and present the details and have the proper discussion, I would like to ask the rector of our university, Professor Nikos Papaioannou, who besides the difficult schedule that he has been having today, in fact, he managed to be with us, and this shows the importance that this university provides and gives to research and innovation. So, Professor Papaioannou.
Thank you. Thank you, Panagiotis. Dear colleagues, it's a great pleasure for me to be here with you and to say a few words. I'm in Athens, unfortunately, because I have 2 meetings in the Ministry of Health. So I find 2 or 3 minutes because I believe in this action and I believe in this project. Additionally, I would like to congratulate Dr. Tomislav Sokol from one hand, and from the other, the consortium of this LifeChamps project, and mostly Professor Pamidis and his team, because as far as I know, Professor Pamidis, he is a strong researcher, a very brilliant researcher, and I think that he coordinates very well these very interesting and very important research and innovation action that is called a LifeChamps. As I saw, there are many universities and institutes that are involved in this action, and I hope that the main subject and the main goal in the end of this action is really very important, because as I can read that the LifeChamps project aiming at supporting and delivering the highest after treatment, care, prevention and advice mechanisms to older cancer patients. This is really, really very important. And according to the program, I showed there is a keynote speaker who is the president of the International Society of Geriatric Oncology. As pathologist, I'm working scientifically in the field of the degenerative diseases, in the pathogenesis of degenerative diseases, especially dementia. I can understand all these ideas and all these events. And again, thank you very much for this invitation. I strongly, as a rector of the university, I strongly support all these activities. And I'm really very proud because the coordinator of this project is coming from our university and is Professor Bamitis. Thank you very much. And I hope that the next 2 or 3 hours, you will have a fruitful meeting. Thank you very much.
Thank you, Professor Papadopoulos, Director. I mean, it's been an honor for us to have you with us and to have your support, not only for this meeting, of course, but throughout the whole project. And I can say that I can feel and transfer how much research and innovation have been reinforced during your rectorship. And I hope this will continue and will be developed further. So thank you once again for supporting us and for being with us despite your difficult schedule today.
Thank you very much, Panagiotis.
So let me start with presenting some details of the project itself, the LifeChamps project. As we start, let me share my screen with you. So LifeChamps, which is named the collective intelligence platform to support cancer champions. It's a project funded by the Horizon 2020 project of the European Commission. And it's quite a big project in the sense that it's being consisted of 15 partners from 10 countries. You can see the partnership here, even extended beyond the EU territory. The main objective, we would like to phrase it in one sentence, is to support quality of life of older adults, basically adults with cancer. So cancer patients, we focus on specific cancer cases, and we focus on the after treatment period. Why do we deal with older ages? Because the incidence of cancer in those ages is much more frequent. So the problem is more eminent, and that's why we focus there. What is also true is that the problem in those ages is more difficult to solve. As we know, there is a frailty, there is a lot of comorbidities, etc., which emphasize the problem even further, and therefore make its solution even more difficult. So there is basically, when treating the cancer in older ages, there is already a gap, we would say, in what doctors can provide as treatment or as interventions. And we would like to overcome this basically this gap, this treatment gap, this care gap. And that's why we focus in these older ages. So current cancer care practice suffers from these signs of this gap, which I would call it ageism. Insufficient care and support for older cancer patients, as well as inequitable access to cancer care, has already led to poor outcomes in this domain. What is also true is that the interaction between frailty and the cancer diagnosis or treatment, in their combined impact on the quality of life of all the cancer patients, is largely unknown today, and therefore it deserves our further research and insight into this problem. The result of all these combination, of course, is that we do have a fragmented model of care for older adults suffering from cancer, and that's what we want to emphasize and have as an objective, and provide solutions within LifeChamps. So we believe in technology in the form of digital biomarkers, digital solutions that can provide links of electronic health profiles with mechanisms to digitize the feedback, the symptoms, the experiences of patients, and as well as the data that can be collected by wearable sensors during daily life activities, etc. We hope that through the collection of these, as well as the modeling of already available data, we will have a big data collection, and therefore we do have a need to build, and we are building the infrastructure for handling these data, and then to provide complex networks analysis or multimodal data analysis so that we can have an induction of what is called the frailty phenotypes, and we can measure and provide digital indices for frailty, before frail, after frail, and how these would fit our data for the different cancer types, such as breast cancer, prostate cancer, and skin cancer. And then we also have a dashboard for patients and a dashboard for the doctors to see how this data collection is going and what is recommended. We hope through this modeling and collection that we do in the pilot that we will make sure that we meet our vision, which is nothing but a society where ageist stereotypes and discrimination against older adults will be eliminated from clinical practice in cancer care. Also, the mission that we are determined to meet and address is the inherent complexity caused by cancer treatments. And we hope that we can act in the monitoring of health status and improvement of quality of care in a significant manner. What do we have as tools? We have emerging developments in the fields of big data, data analytics, artificial intelligence, and health in general, mobile health in general, that we hope that will provide an enhanced arsenal of tools that will fight this problem. So I'd like to thank you for your attention, and we can actually continue with the rest of the program, Harris, I guess.
Yes, of course. Thank you so much, Professor, for a very good summary of the project aims. Next, we will hear from Dr. Antonis Bilis, the LifeChamps Scientific Coordinator, and he will present on the innovative aspects of LifeChamps and technical and methodological specifications. So, Antonis, the floor is yours.
Hello, good evening, everyone. So I'm going to give you a brief introduction about the different technical and methodological specifications of the LifeChamps project. And in the beginning, I will give you in a nutshell what is the LifeChamps technology about. So our main aim is to design, implement, deploy a digital platform, which is consisting of a sensing platform with different smart devices, mobile application for patients, a dashboard for clinicians, a big data infrastructure, and of course, a sophisticated data analytics engine for predictive analytics. Main sources of data for achieving this, this smart, let's say, application for cancer care, the older adults, comes from electronic health records, patient-reported outcomes, apps, wearables, sensors, and environmental sources. So what is the patient application for the quality of life assessment? For the patient, what we deliver as LifeChamps project is an application that will provide the possibility to measure symptoms, experiences of patients through simple questionnaires that will allow their self-assessment of their quality of life. Also, what we provide is simple contents, educational contents that are adapted both to breast, prostate cancer, but also to skin cancer. Also providing some kind of motivational messages that will empower patients to care for themselves. In addition, what we have managed to integrate in this mobile application is different sensors like wearables or smart devices like smart scales or environmental monitoring sensors that are being placed in the home environment of the patient and try to understand activities, patterns, like sleeping patterns, like mobility patterns, etc., but also patterns that are relevant to older age, like TV watching, for instance. So we use smart plugs for this reason, to understand the activity of usage of electrical appliances. Also, what we include as smart sensors are smart t-shirts, which are smart textiles that include sensors that can measure in detail vital signs of patients or mobility patterns. In addition, we include also information from online sources that are relevant to the skin cancer paradigm, like the UV radiation exposure. So all this information, if they are combined in a smart way, they can provide us with some behavioral metrics, which are then can be correlated with clinical assessment provided by the healthcare professionals. But what is the advantage of having such kind of information available to healthcare practitioners? This data can be collected every day outside the clinical practice, and they can be available to clinicians in more detail for a long period of time, thus giving the opportunity to clinicians to have the full picture of what is the progress, what is the deterioration probably of quality of life of older cancer patients within the visits that they do in the clinics. So apart from the mobile app, we provide a dashboard for the clinicians, which is split in three parts: a web application for patient level monitoring to understand the patient progress, individual patient health, ill health trajectory modeling to see transitions between a healthy status to a disease status, but also to provide statistics about cohorts being monitored at a hospital level. Here you can see some examples of what we have developed so far, like the patient level dashboard, where you can see individual scores of questionnaires or the levels of activity or the sleep quality as being collected by the smartwatches. Or you can see here an example of the statistics that we may provide at the hospital level, at the clinic level, for the clinicians to understand what is their cohort, what are the main key process indicators, and how they can probably improve the care they provide to clinicians. So here they have insights at the cohort level. But what LifeChamps also introduces is that we do not create this only by ourselves, but we include also experts, geriatricians or oncologists, into developing these clinical models. So at the core of our design of our algorithms, we consult closely with clinicians. And here you can see some examples of how we built our models with and for the clinicians through interactive workshops. Of course, as I said, it's not really work that we perform inside our consortium, but we try to include our stakeholders. We have recognized our stakeholders and we're trying to include them as more as possible. So we have performed a lot of workshops online and of course offline, face-to-face. We have included more than 150 stakeholders across EU. We have launched an online survey where we have asked the opinion of cancer survivors with the help of ECPC. We have included also the International Society of Geriatric Oncology when we try to design our models and of course gather the requirements for developing the solutions, both the mobile app and the dashboard, so that in the end we do not provide something that is useless to them. So we try to constantly include them in all of our activities. And this is one of the most important aspects of our methodology. Apart from that, we have organized and we are trying to move our approaches towards what has been recommended by the European Commission as oncology-focused living labs, which is a structure that can play an intermediary role that will drive the digital innovation in cancer care and deliver new digital innovation tools. And therefore we have performed a workshop during Digital Living Lab Days past September, where we tried to map us further in the right on that. But this is what we are trying to achieve. Thank you very much.
So thank you so much, Antonis, for the very comprehensive presentation. The first part, the presentation of LifeChamps, is now completed. So we will now proceed with a keynote speech and the panel discussion. So with no further ado, I will pass the floor to Professor Bamidis to introduce today's keynote speaker and moderate the panel discussion. So Professor Bamidis, over to you again.
Thank you, Haris. I think it's not only a pleasure, but an honor to introduce to you Dr. Niccolò Battisti, who is not only the president-elect of the International Society of Geriatric Oncology, but he is a person that he knows this field very well. And he has been collaborating with us for the last few months, rigorously, I would say, because we have been discussing options and possibilities and the ways that the society, which is a very important one, CIOG could assist in our project. So it's a pleasure and an honor, as I said, to introduce to you Niccolò today, who will talk about cancer care gaps for older patients with cancer and the implications for research and innovation. So Niccolò, thank you very much. The floor is yours.
Thank you very much. Thank you very much for the nice introduction, Professor Bamidis, and thank you very much, LifeChamps and ECPC, for inviting me to discuss with you what are the really key challenges and gaps in the care of older patients with cancer global level. I'm a medical oncologist. My disease-specific interest is breast. I work at the Marsden in London, and I am obviously very interested in the field of geriatric oncology. I am the president-elect of CIOG, which is an international professional society grouping all researchers and clinicians with an interest in geriatric oncology from any background, so medic, nurses, and allied care professions. These are my disclosures. Why it's so important to raise awareness about the care of older patients with cancer globally? Well, this is because of the demographic changes that we are now observing, not only in high-income countries, but also in lower and middle-income countries. These on the left are data from the Office for National Statistics in the UK. As you can see here in this country, we expect by 2043, 1/4 of the general population to be age over 65. And if you look at the characteristic, the age of cancer survivors, there are very interesting data from the States, the SER database, that really demonstrate that what is the sheer increase in the older age group within the population of cancer survivors. By 2040, they estimate there to have 73% of cancer survivors age 65 plus, with a really significant increase, especially in the older age groups as opposed to the younger ones. And this is obviously because we are becoming much better in diagnosing early and treating more effectively cancer, which really suggests that this is becoming increasingly a challenge for healthcare systems and clinicians worldwide. However, on a sadder note, there is the key challenge in geriatric oncology is really that we have substantial gaps in the knowledge of how we should best treat older people with cancer. We've been knowing this for more than 20 years. In the late 1990s, Laura Hutchins showed that among the participants to SWOG, so a cooperative research group, clinical trials in the States, only 25% were age 65 plus, versus 63% in the general US cancer patient population at that stage, with some significant gaps, for example, between trial populations and real-world cancer patient population, for example, in some specific tumors, like, for example, breast. 15 years later, Arteria was a giant in the field of genetic oncology, looked again at recruitment of older individuals in the NCI-sponsored phase 2 and 3 clinical trials, again in the States, and found that, again, less than 10% of those patients were age 75 plus, as opposed to 28% in the general US cancer patient population at that stage. And this is a key initial challenge that really suggested the evidence that I'm using every day to guide my discussion with patients in the clinic may actually not always be very easily applicable in the real world. Another key challenge is variation in outcomes. And for example, this is a beautiful analysis, UK5, that looked at data from more than 10 million patients with cancer among more than 100 cancer registries. And as you can see here, compared with the younger patients, as expected, there is a decline in the age-specific relative survival at 5 years. But there is also variation across different countries in the older age group, which, for example, above the age of 75 goes, for example, in Europe from 65% in Northern Europe versus 76% in Southern Europe. But another issue is that there is significant variation not only in outcomes, but also in treatments that we are delivering for older patients with cancer. And again, here I'm showing you some example, obviously from my main interest, my disease-specific interest, which is breast. Data from, on the left, the Bridging the Age Gap study, which is an observational study that ran here in the UK between 2013 and 2018. And looked at treatments pursued for more than 3,000 older patients over the age of 70 with primary breast cancer in England and Wales across 56 breast units. So real-world patients, real-world treatments. And as you can see here, this study included assessments of fitness or overall health that are sometimes not always easy to retrieve in clinical trials. And even when we select patients based on fitness, or even when we define patients, when you look at the treatment of fit patients with high risk breast cancer, so typically a negative and not positive, so a population of patients that we would deem able to benefit from chemotherapy, well, less than 1/3 of these patients actually did receive chemotherapy. And this suggests that there is obviously substantial risk of under-treating these patients. Again, on the right, these are data from another analysis conducted on cancer registry dataset here in the UK, the SACT dataset, which is a registry looking at the use of systemic anti-cancer treatment for patients diagnosed with cancer, again, in England. And this was a large analysis. I'm showing you just the breast cancer cohort again. And in these funnel plots, you have on the x-axis, essentially the caseload of each individual hospital, which is represented by each one of these circles. And on the y-axis, you have the rate of use of systemic anti-cancer treatment in these different hospitals. As expected, there is obviously a lower rate of systemic anti-cancer treatment use in the older age group with an age cutoff of 70, but there is also significant variation in the use of chemotherapy and other systemic treatment in the older age group versus the younger age group. And these were data that were adjusted for case mix for essentially tumor characteristics. And even when we looked at, for example, the highest risk, the highest risk breast cancer subtype, so the negative group, again, we documented much lower rates of systemic treatment use in the older patients versus the younger ones. And this is something which is also it's also been demonstrated at international level. If you look again at the Eureka breast cancer group analysis that was conducted a few years ago by some colleagues in the Netherlands on a very large data set of patients over the age of 70 with, again, no metastatic breast cancer, you can see the degree of variation in the use of surgery or primary endocrine therapy for patients with curable breast cancer across, for example, the Netherlands, Belgium, Ireland, England, and Poland. Obviously, a key challenge is that all the adults are heterogeneous. As we age, we become increasingly diverse because we are exposed to a number of factors, including obviously different health behaviors. We live in different places of the world with different level of access to healthcare. We may develop comorbidities, we may have different levels of social support. And as a clinician in the clinic, it's quite common to see at one end, very fit older patient with a longer life expectancy, good functional status, no comorbidity, major comorbidities, no polypharmacy, good organ function reserve, where the focus on my recommendation could still be survival. Whereas on the other end of the spectrum, we see very vulnerable individuals with a short life expectancy, a high burden of comorbidities, polypharmacy, that are at high risk of toxicities from standard anti-cancer treatments, where the focus should be increasingly quality of life. And obviously, the key aspect here is to determine who are those patients that can actually benefit from and tolerate standard anti-cancer treatments versus who are those that actually requires an adaptive treatment plan. And the solution to this is obviously comprehensive geriatric assessment, so the integration of principles of the general geriatrics to the field of oncology. CGA is something that we have been learning in the geriatric oncology field from our obviously geriatrician colleagues. CGA is a diagnostic and a therapeutic process that investigates with a number of validated tools and tests domains that are crucial to the well-being of older patients. And these domains are obviously comorbidities, polypharmacy, functional status, cognitive status, psychological status, nutrition, geriatric syndromes, within a multidisciplinary setting that goes beyond simply the traditional structure of a multidisciplinary team, including obviously medical oncology, radiation oncology, surgery, and so on, but includes, where available, geriatricians, nurses, dietitians, pharmacists, physiotherapists, occupational therapists, social workers, psychologists, supportive care teams, and with close involvement also primary care and community services to really provide these patients a holistic approach. And why is that so important? Because historically, we've known that there are several benefits to be achieved with an oncogeriatric approach. And these benefits are obviously being much better in predicting complications, functional decline on anti-cancer treatment, prognosis, shift, change, treatment decisions, finding problems that are very frequently neglected by the routine assessments. And last year, at the American Society of Clinical Oncology conference, 4 randomized clinical trials reported looking at outcomes for patients with cancer randomized to an oncogeriatric approach versus standard care, so routine care. And the geriatric oncology community got very excited because the benefits for the first time that we were seeing in these trials were benefits that usually the oncology community finds far more attractive. And these benefits are a reduction in the risk of severe systemic treatment toxicity and unplanned hospitalizations, a reduction in the rates of early treatment discontinuation, an improvement in quality of life, again on systemic anti-cancer treatment, increased completion of advanced directives, and for surgical patients, a reduction in the postoperative inpatient stay and intensive care unit admission. And this is now an approach that international guidelines, not only SIO guidelines, but also American Society of Clinical Oncology guidelines and the NCCN guidelines are recommending and defining as a true standard of care. There is a fantastic opportunity with an oncogeriatric approach also to foster the upskilling of the cancer workforce in the principles of geriatrics, which is sometimes a bit patchy across different countries and different disciplines. This is, for example, a very nice study that a geriatrician that works here in the UK, Tanya Calsi, leads an oncogeriatric service in a big center here in London, showed actually what is the need, for example, for oncology, medical oncology trainees in terms of training in geriatric principles. These are professionals that will be seeing routinely and predominantly older patients in their clinics, and they don't have any training in these principles. A key challenge is also how do you actually set up these models in your routine practice. The literature suggests that the algorithm is usually very similar. So you should use a specific tool that we call geriatric screening tools to actually determine who are those patients that you can treat like the younger counterparts versus who are those patients that actually need some enhanced care, so an oncogeriatric approach, so that you can actually better allocate resources rather than doing CGA for every older patient. And in terms of models of care, if you look at the literature, there are essentially 3 main models of care that are available worldwide. And these models are a consultative model first, where essentially you have an oncology team that refers patient to a geriatrics teams for a geriatrics workup. And then the geriatrics teams refer patients back to the oncology team for ongoing cancer management. A shared care model where the oncology teams work alongside geriatrics teams throughout the whole treatment pathway of that individual older patients. A comprehensive model where there is a lack of geriatricians, where you set up a multidisciplinary geriatric oncology team, including obviously oncologists, nurses, and also a number of allied care professions able to provide that specific holistic care to these patients. And these models are now diffused worldwide. Obviously, the field of geriatric oncology was born in North America and in Europe, where we have very mature geriatric oncology programs, especially in the States, in Canada, in France. In France, the National Cancer Plan has been funding the creation of these geriatric oncology units since 2006. But now increasing also in other countries, in Europe, but also in other areas of the world, Latin America, Oceania, Asia, that are obviously seeing the very same demographic changes that we are observing here. And geriatric oncology is also a fantastic opportunity to, as we say, geriatricize clinical trials. And this means essentially make clinical trials in oncology far more meaningful than they currently are for older patients with cancer that are going to be the most frequent end users of whatever new treatment approach those trials are investigating. There are opportunities to expand the eligibility criteria of clinical trials and allocate patients to different treatment based on fitness. So try and recruit more vulnerable and frail older patients to trials to again expand the applicability of their findings to real-world populations, but also the importance of selecting endpoints that are really meaningful for older individuals. And these endpoints are not always survival outcomes, but also quality of life, impacts on physical function, impacts on treatment tolerability. It is absolutely important to include geriatric assessments in clinical trials, probably as we have seen, for example, from the Bridging the Age Gap study, because this allows me really to understand how fit or unfit that patient population are, to allocate patients to different treatments based on their health, and to predict also the toxicity they may experience on whatever anti-cancer treatment. And there is also an opportunity to use, for example, novel trial designs like Senate trials, dogmatic trials, prospective cohort studies to really understand what are the patterns of care in this patient population. This is a very nice publication that my mentor, Martin Exman, that leads the Senior Adult Oncology Program at Moffitt in Tampa, Florida, published with the SIOG working group earlier this year in Lancet Oncology, to really outline what are the priorities to really develop, expand, improve the care of older patients with cancer global level. It's all about education, of course. And as I mentioned, embedding geriatrics in the curricula or training curricula of the cancer workforce, including medics, nurses, and obviously AHPs. but also increasing awareness among patients and in the general population about these aspects. Second, it's all about improving clinical practice, so developing, implementing these oncogenetic models of care in routine cancer care, develop guidelines that actually are able to, guide clinicians in their routine recommendation for this patient population. This is obviously what SAIG is quite involved with. And third, obviously improving research, the relevance of clinical trials, embedding genetic assessment in trial design, and perhaps also use personalized medicine technologies to really make the care of these patients much easier and straightforward. And collaboration, obviously, collaboration among professional societies, the cancer workforce, agency, LifeChamps, ECPC. It's all about working together from our respective points of view. And this is my last slide. Oh,
please,
sorry.
Okay. Yes, please conclude so that we can come.
Oh, sorry. Yeah, just to say, this is how I see geriatric oncology. This is also obviously precision medicine. It's looking at the tumor with a number of biomarkers, and now we are using routine practice, but also looking at the host of that tumor, moving away from simply performance status, chronological age, but look at CGA as an opportunity to get a better understanding of pros and cons of specific treatments. Thank you very much.
Thank you very much, Nicolo, for such an inspiring, as usual, presentation, pinpointing to the problem very well. So let us now proceed with the panel discussion, in which we have, additionally to our MP, Tomislav Sokol, and Nicolo Battisti, Professor Mark Lawyer, who is the ECPC Scientific Committee member, but also professor at the Faculty of Medicine for Health and Life Sciences at the Queen's University in Belfast, as well as Alina Comanescu, the founder of Asociația Sanitate pentru Comunitate. It's the Community Health Association and Patient Representative, if I have pronounced that properly, and Dr. Evdokimos Konstantinidis, who is the president of the European Network of Living Labs. They're all with us today. Let me first of all start with a question to our MP, Dr. Tomislav Sokol, because I know he's got another sort of duty and he will go soon, by asking, there is a need to design and promote together efficient and sustainable electronic health or mHealth and digital personalized centered cancer care models. These need to be turned into concrete policies, obviously, in the following, or perhaps just in the coming year. So how do you see the role of all these, especially tools, telemedicine, and is there already a plan for preparing healthcare systems and healthcare authorities in Europe?
Yes, thank you very much. Yes, I will have to leave in about 5 minutes because I have another engagement related to healthcare, actually about equality of access to cancer at 3 p.m. So this is the reason why I have to leave. So when we say this, of course, European Union is there to help the member states. So that's the first thing. Obviously, the member states are those who have the autonomy to define what they will finance and how they will organize their systems. What the EU can do is to support their policies financially and in other ways. And I'm glad that in Directive 2011/24 on cross-border healthcare, we have the legal basis to actually discuss telemedicine on the EU level. So there we have a set of rules and the procedures on how to coordinate different national policies in related to telemedicine. So I think that this is very important. So EU has already done something on that. What I think is crucial is to see what its role should be, and I believe that its role should especially be important in cross-border healthcare, for instance. And if this is connected to European reference networks, so in many cases, you as a patient who suffers maybe from rare disease cannot get adequate expert opinion in your own country, but you could get it through telemedicine, medicine through e-health, through European reference networks from experts from other member states. And I'm glad that I was able to include in the Becker report the so-called right to second opinion. So the right to get a second opinion also from experts from other member states, and not just from your own country. And for this, we can use the European reference networks and the telemedicine as a tool. This is where telemedicine is important. I think telemedicine is also important in rural areas where actual physical access to healthcare is impeded, where you have to travel 50 or 100 kilometers to get to nearest doctor. And here telemedicine can really help and facilitate access to medical diagnostics, to medical expertise, etc. Of course, in order to facilitate this, we need the basic infrastructure. We need the adequate internet connection, and here European Union through the RRF program, through the European cohesion policy, can also do a lot to actually provide rural areas, villages, small towns in different member states actual access to broadband internet, which can then be used to facilitate the e-health. So I think that in this sense, what EU can do is to really help financially to provide this basic infrastructure, especially in rural areas. It can also help through the organization of European reference networks for cross-border healthcare. And regulatory, as I already mentioned in the beginning, so I will not go into detail, but I think that European health data space regulation is crucial, because this should provide the interoperability of data between different member states. And I think this is one of the major requirements if we want to use data and expertise to really have this cross-border collaboration and cross-border healthcare, where, of course, which can also obviously can be conducted through telemedicine. And of course, one of the big issues is that the protocols and standards of how to use telemedicine are also different between member states. And here European Union cannot harmonize, so it cannot impose one unified set of rules for all the member states, but by exchanging good practices, issuing non-binding guidelines and things like that, and working on these European reference networks on the exchange of expertise, I think that some common standards can be made on the European level, which then member states would voluntarily accept. Because I know that there are big differences in terms of how to regulate telemedicine. So I think EU, even though it cannot legally impose telemedicine in the same way in all member states, but I think it can use its financial and regulatory instruments to really facilitate its adoption. And this can really help people, especially in rural, remote areas, patients who suffer from rare diseases, who cannot get adequate healthcare in their own country. And I think that this is very important for that reason. And I think that now that situation will definitely improve in the years to come.
And thank you very much. And if we can refer to the COVID-19 crisis that we have been experiencing in the last couple of years, are there any lessons learned at the European, at the policy level, that we could perhaps provide solution for seamless cancer care in specific with new tools and telemedical solutions, for example? What is the message that we have learned so far so that we can fight future crises as well?
Yes, I mean, telemedicine will become much more important because because it can actually be used to rationalize a lot of things and get rid of redundant actions which are not necessary within the system, and actually reduce expenses. And I think especially in the area in the situation with COVID, this is very important because I think oncological patients are maybe the category which has suffered the most, apart from those who actually contracted COVID-19, but who actually suffered the most because of the focus of the health systems on COVID-19, and all the capacities were focused on COVID-19, and oncological patients have really suffered because of this. So I think one of the lessons learned is that our systems have to be more resilient. They have to be better organized. I think that they need to be. We need to have protocols on how to deal and priority setting in cases where we cannot cater to all the patients because of the lack of capacity. So I think that, but this is the question of organization of the systems, and I think that we've we've been able to identify bottlenecks where additional investments are needed, which can also be provided on EU level. And of course, telemedicine definitely has a role to play, because if it can be used to rationalize the system, if we can avoid having physical contact maybe, and we can use telemedicine for this, then this can definitely help healthcare systems better cope with this lack of capacity, which is devoted mostly to COVID-19. So I think that we have learned something, but again, the implementation and the responsibility in the end will be on the national systems. And here, which is always the problem, because there are big differences, but I think that the European Union should be much more active in communicating with them than it was before, and I think that this will be the case.
Thank you very much. I think you are just emphasizing in your concluding remark that obviously scientific societies can also play a role, and I think Nicolo has already mentioned that in his slides regarding the priorities set by CIOG, for example, in which education could be one of the ways that we train people, we train the system itself perhaps to fight against this. And thanking you again, Tomislav. I'd like to address my next question to Nicolo, in fact, given his experience obviously in cancer care, but also during the COVID-19 pandemic. How do you see, Nicolo, the telehealth as a bridge or a barrier, perhaps, for a better quality of care for older cancer patients? What do you think about this?
Thank you very much, Professor Bamidis. I would say that it's a double-edged sword. I would say that there are fantastic opportunities with telehealth to improve the care of older patients with cancer. We've seen that a lot during this COVID-19 pandemic, because obviously we have, to a certain extent, become much more efficient in the delivery of care, especially for this patient population. They may have significant sometimes issues with traveling to hospitals to attend appointments for blood tests, to get treatments and so on. For example, we can deliver specific treatments at home for our patients with home care services. We can deliver also blood tests at home. We can conduct remote consultations with these patients. We can also conduct geriatric assessments remotely. This was beautifully presented in a very nice pilot study from our colleagues at University of Rochester, New York, last year. But the crucial aspect is that we should always bear in mind that we should personalize these approaches, because there may be patients that actually are not suitable for these approaches. They may not feel confident with technology and may still prefer to come and see us, for example, in person in the hospital. I remember seeing a number of patients during the first few months of the pandemic that were obviously shielding. And they were absolutely very happy to come and see us in the clinic, because that was the only opportunity for them to leave their home. I've seen lots of deconditioning in this age group, because obviously patients have been conducting obviously much more sedentary lifestyle. They've been stuck in their homes and so on. You have to bear in mind also the increased prevalence of visual and hearing impairments in this age group. So again, the key aspect is, to me, personalize this approach. Use them where appropriate for patients that actually can benefit from them and can really fully engage with their clinicians with telehealth, and perhaps still stick to more traditional ways of delivering care for those patients that are not suitable for this approach, rather than, for example, going for a blanket policy with telehealth for everybody. It's the same approach that we are advocating for when it comes to specific anti-cancer treatments. So again, personalize the approach based on the individual needs and patient circumstances.
Thank you very much. I think you just pinpointed personalization as one of the key drivers for developing well in this in this route. Do you think that the healthcare providers are sufficiently trained to work through all these difficulties and through this new status of the problem?
I think there is still a long way to go in the sense that there is a huge variation in, for example, the training and the education of the cancer workforce across different countries. As a doctor, I train in my home country, Italy, and I had really to proactively seek training in geriatric principles, because otherwise I could have absolutely graduated, let's say, as a medical oncologist without getting any big deal of training on these aspects. This is, for example, why SIOG is organizing every year 2 editions of an advanced course in geriatric oncology in Treviso and Canberra. So I think that's the first aspect. The second aspect is to remember that, for example, what we are advocating for is not really rocket science. Sometimes, the approaches that are useful, the interventions that are useful to improve the care of all the patients with cancer, to improve the safety of treatment, to improve the quality of life. Sometimes they simply take some common sense rather than any specific or complex approaches. And this is more of a change. This requires more of change in mindset of the cancer workforce. When we look after all the patients with cancer, we really have to look at the full picture, just beyond simply the tumor. Look at the patient, look at the individual needs. Focus on the same considerations that you would bear in mind for younger patients when there are no other concerns, and look also at additional issues, geriatric impairments and so on, where these actually exist and may impact significantly, as we have seen in the efficacy and the treatment of anti-cancer treatment for these patients. So yeah, this would be in a nutshell my thought.
Thank you, Nicolo. You just highlighted the essential bits, and there is still a long way to go for training the whole stakeholders network, I would call it in this way. And I'd like to turn now to Professor Leuler. Mark, you have we have new models of research and innovation, and there is all a new setting of a new environment, I would say, where we could build more patient-centered research and care model provision, especially for these older patients with cancer. And how do you think, what is your vision on how the academic and research environments could perhaps invest more on these models so that we can address better the challenges and the inequalities around Europe?
Thanks very much, Panos, and a really interesting area. I mean, it's interesting. Back in 2014, we actually wrote an editorial in the British Medical Journal saying ageism in cancer care, we need to change the mindset. I would have said up to last year, we haven't actually seen a lot of progress in this area, but thankfully we've now seen, and Panos, you yourself highlighted the ageist aspect of, unfortunately, how older patients are treated at the moment. But I think what Nicolo showed us is that geriocentric approach is what I would call it, so that there needs to be a geriocentric approach, and Nicolo has shown that in the context of clinical trials, in the context of really thinking about things much more personalized. And I agree with them. I think this idea of actually personalizing care to the older patient is really important. I mean, we have to remember, age is just a number. So we really need to be looking at the much more personalized approach to the patient. I think we're in a crucial inflection point at the moment. I think we have a European Commissioner who's focused on cancer. We're voting today on the Europe Beating Cancer Plan. We have the EU Cancer Mission. So I think we're actually in a really good position. But we have to hold our nerve, and we really need to hold our nerve in terms of making sure that what we deliver is for all of Europe. I think that's one of the things, and a number of the speakers highlighted it earlier in terms of the importance of using data, first of all, I think is critical. And it's interesting, I looked back at the paper we wrote in the British Medical Journal, and one of the things we highlighted, even though it was back in 2014, was the need to have more data to understand what the inequalities were. I think we now understand what the inequalities are and the details of that, but now we need to do something about them. And I think in order to do that, we need to use the data to our advantage. We need to turn that sort of information into intelligence and use that to then underpin our research programs. We still do, sort of proportionally, less research in older cancer patients, and I think it's really important that we focus on that. And that's why I really, commend you on the project that you're doing at the moment, LifeChamps, because it needs that type of, detailed, in-depth research that actually then points or illuminates the way to go. For the cancer patients, it's really important that they're involved in that process as well. And obviously the European Cancer Patient Coalition have been at the forefront of that. That's sort of not only patient-centered, but also patient-involved, co-created with patients. And we certainly find in the UK, working closely with patients is a very good way of delivering better research, and also obviously that leads to better care as well for patients. We know that patients who are treated in research active hospitals have better outcomes than those who are not. And so I think we have a good opportunity, but the important thing is we need to grasp it. And I think using data to help us on that journey is to illuminate the way to go is really important.
Thank you very much. I think that also the COVID situation has highlighted the importance of data, because I think you can do nothing unless you have data to support your statements. And I think this has been especially emphasized in the last few years. It started slowly but surely in the last decade, as we just said. I mean, already back in 2014, you have already mentioned and highlighted that. But I think it's now obvious to everybody that unless you have evidence from data analysis, you cannot claim anything, actually. So thank you very much for highlighting this very important point. I'd like now to turn to Alina Comanescu. And Alina, during the past years, there has been a lot of improvements in terms of cancer patients' involvement in research and development projects in general. Would you say that this is also the case for older patients, for older adults involved in the research efforts?
I would say that we are not quite there. Although the majority of cancer incidence and mortality occurs in patients 60 years old or older, this age group is still underrepresented in research, as the patients who are eventually chosen to participate, especially in clinical trials, typically have a good performance status and no significant comorbidities. So they're not representative for older patients populations during this clinical trial practice. Consequently, there is a gap of evidence for older cancer patients, and oncologists are often forced to extrapolate treatment plans for them based on the data from younger and healthier patients. This practically means in most cases the recommended treatments are different for older cancer patients, and some of them may even experience treatment-related complications. There needs for more research. There is need for more research with a special focus on older cancer patients with complications and comorbidities, which including geriatric assessment in randomized control trials. More information could be provided with regards to which patients benefit the most from the cancer treatment. This type of clinical trials should explore all relevant factors associated with these new modalities. So telehealth can help in this case by giving access and remotely including older and frail patients into clinical trials, but also provide technological solution which fits their needs. However, a very evident barrier concerning any new technology would be the accessibility and the understandability of it. because telehealth tools for older people need to be adapted to their knowledge and needs specifically, and sometimes additionally help is needed to be provided in order for them to use such tools. Thus, I have to stress the importance of patients' associations' involvement in both the development and the promotion of this particular telehealth solution in cancer research and development.
Thank you very much. This is particularly of interest for our project because we are dealing with these kinds of ages, obviously, but also we involve new technologies and telemonitoring and telehealth, as you have seen, in the sense that we need them to use these technologies to provide the data that we so much need. And therefore, we do expect specific challenges during the next few months, in fact, that we are starting the pilots. And, any lessons learned will be specifically welcome to us as recommendations and recipes of success. Thank you very much for these important points. I'd like to turn now to our last but not least panel member, Dr. Evdokimos Konstantinidis, and ask him, how do you see, Evdokimos, the involvement of oncology-focused living labs in this domain? Can they contribute to the well-being of older cancer patients? Can they provide new solutions back to the community? How do you see the role of these? And you can give us a couple of points also on the notion of living labs themselves as well.
Thank you, Panagiotis. There are a lot of examples where clinical studies have proven the effectiveness of an intervention, but patients do not follow it in real life. And this could be for many reasons, such as they don't like it, they feel it steals their time, or they don't see the value. And for this reason, ENOL has already been invited to discuss with the European Commission Cancer Mission Group and to present the living lab methodology. And actually, they are interested in learning more about living labs and how they conduct studies in order to potentially include such ways in the forthcoming calls as additional research approaches. As a response to this invitation, the oncology-focused living labs of the ENOL network organized themselves as a working group and went through a series of telcos, exchanging knowledge, experience, and good practices. And the added value of the living labs in the domain is the methodological approach of the solution that will increase the value, not only for the patients, but for all the involved stakeholders, relatives, hospitals, academia doing research on the topic, policy making, and targeted funding, actually. And this is because living labs have in the heart the innovation, open and user-driven innovation, and not just testing or validating. And by open, we mean that living labs tap and the knowledge and know-how that exists outside there, beyond our organization, by engaging other stakeholders, and user-driven innovation because living labs actively and directly involved throughout the innovation development process and users, citizens, clients, or as I mentioned before. And this is, innovation should not be just about technology, but about implementing new or improved goods or services, processes, or even new organizational methods in business practice or workplace organizations.
Thank you very much, Evdokimos. I think it is quite important that the European Network of Living Labs is already considering this case, and I think there will be quite a good interest, especially in the forthcoming program of Horizon Europe. And I think it is essential that the only, to address the one point, that the only way that we could bring patients more involved, we could bring the whole sort of stakeholders network more involved into this problem is perhaps through a different approach. And I think living labs have got the essentials as an approach and a methodology to bring about new ideas and new insights into this kind of research, to make it more participatory. Thank you very much. And I'd like to ask if any of the other speakers want to interact and ask anyone of the other speakers anything else. And obviously the Q&As and the chat buttons are always open if there were any questions from the audience as well. Please place your questions. Yes, Mark.
Yeah, Panos, sort of a bit of a statement and then a question. So this is something I asked last month at the European Cancer Summit. I asked people two questions. It's in relation to telemedicine. So the first question I asked them was, when you met people who you'd never met before except online, live, when you met them face to face, were many taller than you had expected them to be? So have people experienced that? Certainly I've experienced that. So they're taller than I expect them to be. So my second question is, when I'm doing a remote consultation, can I judge the weight loss of a patient by just looking at them? So I think we just have to be careful that, yes, telemedicine can do a lot of good things, but I very much agree with Nicolo. It needs to be tailored to the particular person, group, age group, etc., because there is a danger that I was asked, for example, to speak on the topic that one of the silver linings of the COVID-19 pandemic was telemedicine. And I actually refused to use that title because I don't think there are any silver linings of COVID. But it just, for example, the International Brain Tumor Alliance have done some surveys with patients, and they come up with some issues to say that, we actually don't like consulting. We actually like, in certain situations, that more face. So I just think it's not the panacea for everything, but I'd be interested in other people's comments on that. Nicola.
Thank you, Mike.
Thank you very much for that remark. But yeah, I fully agree, Professor Lohr. I think
Mark,
for example, Mark. Okay, thank you. Because for example, if you think, as you said, weight loss, how can you judge that on Zoom? Or, functional assessments. I know that there are some places where, for example, they conduct also functional assessments on Zoom, sit to stand, various other, functional status assessments. But what if that patient falls in front of you on Zoom? What do you do? So it's also, as you said, you need to be very, very careful. You need to be very pragmatic, and you really need to understand whether telehealth is really fit for everybody. And again, as we discussed with in the older age group, we are looking at an incredible diversity of experiences, circumstances, and so on. So I think it's up to us, to be honest, as clinicians, like we would normally, say, that person, I'm going to offer that specific treatment because I think that person might benefit and may tolerate it. That person maybe not. So again, use the same approach with telehealth. As I said, it doesn't mean that I am not supportive of that. It means simply that we need to be extra cautious is right for everybody. I see that there is also another question, I think, for me in the chat box about the challenges that we foresee in the engagement of professional and participatory research with patients. So I think, well, this is something that we probably could speak for hours, but I would say that in my experience, when I discuss research opportunities in geriatric oncology, this is a no-brainer for many of my colleagues. And you might think that actually, let's say, the field of geriatric oncology is is all about preventing over-treatment and is all complex and so on. But actually, in my experience, many of my colleagues are incredibly supportive of this approach, supportive of conducting and participating in clinical trials in this field, because they find it an incredibly rewarding experience, because, as I said, you're really doing something incredibly personalized. You're really, using your skills and your knowledge as a clinician to get best outcomes for that specific person, or investigate a question. And I showed you that there are so many questions that are not answered. So yeah, I mean, my recommendation would really be start talking about these aspects with your colleagues, and look at fantastic examples like, for example, LifeChamps, or other experiences that are really giving us a better understanding of these aspects in the real world, and go for it. Thank you.
Thank you very much. If I wanted to sort of insist on the tools and the need for training that we have highlighted just earlier, I mean, do you see any point in innovating this space of training as well? And can we actually make good use of innovative tools for training now, just for training on this very domain? Is this a field where you can see a need, and you can see development in the next few years that will benefit cancer, geriatric cancer research, and the impact on patients? What do you think, Nicolo?
Absolutely, I fully agree. Within SIOG, we've been conducting our advanced course in geriatric oncology online for since the pandemic kicked in, to be honest. So in my experience, this is just as effective as other ways of delivering education. And as I say, actually, it might actually be easier for a wider population of clinicians and researchers to engage with education with, again, online tools or technologies and so on, other than using more traditional and frontal approaches. So I don't mind, to be honest, and I think there is, again, this is also a good opportunity to reach out to a wider audience of trainees and attendees that may not actually be able to travel long distances, may not have funds to do that, and so on. Yeah.
Mark?
Yeah, I mean, one of the things that we've been doing a lot is, because we've just built a new center, is simulation. And training people, particularly in the terms of the opportunities with older people in relation to simulation. So I'm a big believer in using technology in that training aspect. So certainly I do think that, as Nicolo said, definitely in terms of some of the courses that are potentially offered, but things like simulation, I think, can be very useful in that setting as well.
Arina, do you think there is a purpose for using technology to train patients for technology?
I think that developing such solution, especially for older cancer patients, we must always keep in mind that not all of them are familiar with technology, because I'm fully aware of the disparities between in regards to IT and C education between Western Europe aging population and Eastern Europe aging population. And in many cases, there is also the reason why they prefer physical contact with the oncology team. And this is also came as a result from the latest TCPC survey on cancer treatment during the first wave of the pandemics. And to stress again the importance of the patient association, by including the patient association in the learning, developing and teaching process of this telemedicine solution for elderly patients, the adherence to using this new created solution of the last ones may be enhanced.
Thank you very much. There was a question in the chat, I think, from Rebecca. Mark, would you like to say a couple of things?
Yeah, no, absolutely. I mean, it's a very good question, and it's very relevant. And unfortunately, there is evidence for that. We've seen that, and a number of other centres have as well. So you're absolutely spot on. And it's, again, one of the things that we haven't thought about in the context of the pandemic, but unfortunately, it is highlighted. So yes is the answer. We have seen some evidence of that.
Thank you. Yes. If I could sort of prolong the previous point and question to you, Evdokimos, do you think there is any point that we can perhaps alleviate some of the hassle of using living labs, for example, to utilize some technological aspects for training patients for their involvement in the high technological solutions?
Yes, for sure. I think that living labs could be used and have already been piloted as training for real life. Environments that look like real homes can can have people there living, let's say, or for a couple of hours, so they can understand the technology, they can see the technology, and they can mitigate the fear that they have in order to accept the technology in their homes. But I would also like to mention that since projects like LifeChamps go ahead with a lot of developments in technology, things that we have never thought of some years ago, maybe training should be for all the stakeholders, not only for the patients, but for the doctors or the relatives, which is equally important from my point of view, at least.
May I thank you?
Yes, I was going to ask you, Andonis.
This was a very valid point by Evdokimos, because I want to express an experience that and feedback that we received.
We just missed you.
That we are going to collect in the LifeChamps projects. I mean, gadgets, sensors, data that they are not sure of their their importance on how to use it in the clinical practice. And as Evdokimos said, I mean, we try to build trust with the patients and make them feel comfortable and also safe when using technology. But what about the clinical experts? How we should find ways and synergies with you in order to make transparent the technologies that we use, the data that we produce, and how you see that the clinical practice is going to, get benefits out of it. Nicolo, if you want to.
Yes, Nicola, I think. And
yeah. Thank you very much, Antonio. Yeah, I absolutely agree. And, for example, what is being said on by Rebecca in that question, and what we've been saying is really that what we need, together, clinicians, patients, caregivers, stakeholders, really fight against, the assumptions that we frequently make on what all the patients can do, can achieve, can regard as important and prefer. And as you say, for example, when it comes to technology, sometimes we make the assumption that all the people are not comfortable with that, where they are, or the opposite. And again, the key word is personalization.
Yeah, just to follow up on that, Antonis, I mean, I agree. Living labs is something we're very interested in Northern Ireland as part of a Belfast Region City deal, and it's looking at ways in which we can work together and use the best options. And again, back to what Nicolo said, it's not having preconceived ideas. It's actually judging the patient on the person you see before you, not on a number that says how old they are. So it's actually judging them on the reality, not on the theoretical.
Thank you very much. I take your answers to Andonis's point as the concluding remarks, I think, because they just summarize essentially in a couple of sentences what we wanted to take as take-home messages from this whole discussion. So I'd like to thank you all, and thank you for attending and presenting your ideas and your giving us your insights into this very sort of high societal problem and challenge. Haris, back to you.
So on behalf of the European Cancer Patient Coalition, but also the Challenge Cancer Intergroup, I would like to also thank you very much for being here today with us, as you always do. And you are supportive to every step that we take. And I also take this as the first step for further collaboration in the future, so that we can provide answers, but also developments that will improve treatment, but also quality of life for older cancer patients as well, and answer the problems that they have to face until today. So thank you very much again. Maybe too early, but enjoy holidays and stay safe. Thank you very much.
Thank you very much.
Thank you.
Bye-bye.
Cheers.
Thank you.
Thank you. Bye.
Bye. Bye. Bye.